Welcome to the EATC podcast, a podcast series by the European Hemophilia Consortium on women and bleeding disorders. Today, we're going to discuss the principles of care for women and girls with inherited bleeding disorders with two patient representatives with long-standing experience working with women with bleeding disorders, Naja Skouw-Rasmussen and Evelyn Grimberg. Naja, can you please introduce yourself?
Yes, first of all, thank you for inviting me to be a part of this podcast. So my name, as Sita just mentioned, is Naja Skouw-Rasmussen, and I am one of the women ambassadors within the European Hemophilia Consortium. The reason why I became an ambassador or patient representative is that I have a bleeding disorder myself, von Willebrand bleeding disorder. So over the last many years, I've been both an active member of the European Hemophilia Consortium Women and Bleeding Disorders Committee, but stepped down a couple of years back. But I'm still serving as a patient representative in the European Alliance of Hemophilia and Aligned Disorders, women's working group, who has been one of the authors behind these principles of care that we're going to discuss later on this podcast. Day-to-day job is actually to work for the European Hemophilia Consortium, but as an innovation lead and working with a lot of other aspects than the specific one that we're talking about today, that is women and bleeding disorders.
Thank you, Naja. Evelyn, can you please tell us a little more about yourself?
Yes, thank you for inviting me as well. My name is Evelyn Grimberg. I'm from the Netherlands, and I have been part of the Women and Bleeding Disorder Committee as well. I stepped down and now part of the EHC steering committee, and I'm having a bleeding disorder myself as well. I have Glanzmann thrombostinea, and since the age of 17, I'm active as a patient representative at my own NMO, but also broader by giving presentations and telling my personal story to to raise awareness about women and bleeding disorders issues, but also about other bleeding disorders than hemophilia. And I'm very happy that I took also part of the principles of care from the Women and Bleeding Disorders Committee of the EHC to raise more awareness for women, and that women have issues as well, and hopefully that we can work on better treatment and care for them.
Thank you, Evelyn. So the EHC had published the Principles of Care in 2021. For those who are not familiar with the publication, what are these Principles of Care?
So the Principles of Care, maybe to give the context, is a publication that came out of a beginning momentum in the bleeding disorder community around that girls and women were underdiagnosed and they were lacking treatment, they were lacking care pathways. And when we looked across European countries, there is a huge diversity in terms of the standard of care. And in order to really try and change that, improve the care and treatment for women and girls, we tried, the patient community and the clinicians community really sat together to really try to figure out how can we improve this. And one of the means to do that is to create a benchmark. And that benchmark is this first draft Principles of Care. That highlights specific themes that we can dive more into, but also really trying to really ensure that the patient community and the broader healthcare community, professional community really are aware and acknowledge the challenges that girls and women are facing and has faced historically as well, because they haven't been diagnosed. And that creates a huge gap in equitable care across Europe that we are all striving to achieve.
Yes, that's true, Naja. And I think the women stand up, and there was really a momentum. We ask for some attention because we are missing information. We are missing to get more into the bleeding disorder community, and we were lacking good care and asked for it. And I think these principles came together with the care providers to help us out with that part. But also to make it better. It's not only about hemophilia, it's not only about boys. And now there's time for the women to also get this attention. And these principles of care will help us to advocate for it, but also to get a better a multidisciplinary team, because women do have different bleeding issues compared to men. We have our monthly issues, we deliver babies who gives extra bleeding issues, and that's different compared to the care that already exists. And now hopefully this will help the women to also, for these specific issues, get better treatment options as well.
Excellent, thank you. Regarding the collaboration between the EHC and the EHEAD, can you tell a little more about how the process started and what it was like working with healthcare providers on these principles of care?
First of all, it was a very organic way of working in the sense that there is a lot of agreement between the patient community and the healthcare community, that in particular when it comes to the committees, at least focusing on women, girls and women with bleeding disorders, that this is something that we need to have this benchmark. We need to really trying to identify what is it that we need to pay attention to improve care. So there was a group established both with patient representative and then healthcare professionals, both gynecologists, nurses, a psychologist, and hematologist. So actually a multidisciplinary team to really try to see what is it that we need to focus on here. The group sort of came together and started to work on it, trying to identify what is it that we need to know. And through that process and through and it was very sort of interactive process. You discuss the principles, you identify the research, and really moving ahead with that. And at the same time, exploring with more patients, do some consultation, both with external patients through the EHC, but also with healthcare professionals, which was not a part of the working group, to hear, do they see anything is missing here, anything that should be highlighted, and based on that feedback, really just put those principles together and then got it published later on. My experience was it was a very, very smooth process, and in particular because I think what was achieved in this group was to really have a common goal about what it is that we wanted, because the clinicians could really see from their side that they weren't able to provide the care that they wanted to. They were getting women in their clinics that had been diagnosed way too late in their life compared to the stories they were telling. When they start to look at registry data, they were able to see a lot of gaps, that women were not suddenly in the registries, even though they would know there should be more women in there. Their diagnoses were not recorded correctly and so forth. So from the patient community and from the patient side, it was, you could really just tell so many different stories that you know from the community about girls and women, again, not being diagnosed, not feeling a level of being hurt, not being recommended specific treatments, and really not necessarily being educated about their own diseases, but really felt they were left alone. And I think that because we came all with those experiences, it was actually quite easy to find that common direction and get it to be a very smooth collaboration.
How did you choose these 10 areas?
So with the process of working and establishing the principles of care, we were both, I think, in the working group, we both looked at the gaps that we acknowledge, both from research and from clinical practice and from the patient community. What is it that we experience all the time? What is it that we see that we need to pay more attention to and focus on? And whereas there's a huge potential to actually improve care, but also get with inspiration from other principles of care, for example, principles of care with inhibitor for hemophilia and other diseases where we know that the principles of care has helped tremendously improve the care in different European countries. So putting all of these things together was actually quite easy to identify the specific areas that we needed to address. And I think one element to this is that we need to recognize that the women has those additional challenges in their life. As Evelyn said earlier, they do have their monthly bleeding, and they also have a reproductive system, so they can carry babies and deliver babies. And that just puts a lot of extra challenges to a lot of girls and women with bleeding disorders. And And that is something the paper really needs to highlight, instead of knowing that, because that's the challenge that is not well addressed. A lot of the other bleeds that the women face, like a joint bleeds, gum bleeds, and all that, it has been dealt with a lot more, because there has been focusing on the male side, or the male patient group, and they have exactly the same bleeds. But because they don't have those additional bleeds, that is where the most improvements needs to happen. And that's also why there is not a lot of talk about joint bleeds or other kind of bleeds, gastrointestinal bleeds or something in these principles of care, because the focus is very much on the additional things that we really need to address.
Excellent, thank you. And how do you think patients and clinicians can use this principle as best to achieve the goal of increasing the standard of care in Europe, but also potentially beyond?
Well, Naja was included into the whole process, and she brought it back to our committee. So she knows about how these 10 principles came here. But yes, more important is how can we use them? And I think from a patient's perspective, having these tools having these principles gives you a tool to advocate for better care. I think many women struggle with getting recognition, or getting seen, or getting understood about their specific issues. And as Naja said, it's more focused on other bleeding symptoms that then already are known by the bleeding disorder community. And it doesn't mean that the joint bleeds and the nosebleeds doesn't matter. They are as much as important as well, but that is easier to cover. What we do not cover that well are the heavy periods and the pregnancy or the deliveries of the babies. And there's also lack of data to do it well. So it's a great advocacy tool to use. And I think also from an NMO perspective, it's a great tool to advocate and to see how their HCCs are dealing with this kind of situations, and also to advocate for better care and a multidisciplinary team if they do not have that yet.
Actually, the role of national member organization was going to be my next question. So if you would like to expand on that or add anything else that you can think of.
I think one of the topics that we are now looking out for is more inclusivity in general, in all, not only in Europe, but also abroad. And that is one of the things. It's not only about women, it's also about the other factor deficiencies and rare bleeding disorders compared to von Willebrand and hemophilia. But it's not always there. It's not always available in an NMO. And this is also something that we can use as an NMO to advocate for better care for women, and to see how the care system is working and where we can provide from it and make it better for all the patients that we are helping out with. That is how I see it. I know it's challenging. It's not always easy for all NMO to do it. You do see NMOs who are more doing more for women, but also for other bleeding disorders compared to other ones. But you can use it as an advocacy tool to at least approach for better care for all people with bleeding disorder.
But I think you, Evelyn, you're also really touching upon an important element of a lot of women have not been recognized. It hasn't been acknowledged that they are having these additional challenges. And by suddenly have an expert group stating that this should be at least a benchmark, these are elements that a comprehensive care center should definitely address and really be conscious about and really implement in their day-to-day work. It really gives them that support and that acknowledgement of, okay, this is not just me as a woman that feels something is wrong, that I don't receive the care that I think I should be able to receive. Suddenly you have that external acknowledgement and recognition of and support in, yes, this is something that you should be able to get as a girl or woman with a bleeding disorder. So I hope this will help a lot of women and girls to really, really get that improvement in care. But it also by having principles of care, one thing is that the NMOs can use it directly to go to their comprehensive care center and have that dialogue about how is it that we provide care for our diverse patient group in our respective country. But it's also shifting the entire conversation in NMOs and in the bleeding disorder community around that we, as Evelyn also highlights, that we have a diverse group and we have different challenges, and these different challenges need to be addressed if we need to have equitable care, which is what we're striving to. So it is really much also changing the narrative in how we speak about people who have to deal with a bleeding disorder and recognizing those different challenges. So that is really how I also see that these principles of care can really serve at different levels to change the way it is today.
Excellent, thank you. So you mentioned a couple of things such as equitable care, changing the narrative, and just referring to the principles of care in general as an advocacy tool. But what would you like to see as a result? How will you know that your initiative has been successful?
This is always a very difficult question.
It is.
It's difficult in the sense that some of these are not measured directly. But some of the things that we can measure, for example, is that we see more women in registries. We see development of specific outcome measures for women, that their symptoms like menstruation is actually recorded, and that there is a whole evidence generation behind all the challenges that women face. When that is in place, then is a time we can see that we have some success, that these principles have actually helped that move forward. But it's also, I think, when we talk to a lot of countries, even though there has been a comprehensive care model in place for decades, one of the specialties that is often lacking is a dedicated gynecologist. So there is quite often, if there is a multidisciplinary team, the multidisciplinarity is mainly combined by a hematologist, a nurse, some lab people, and a physiotherapist. But when you, as a woman, have all these additional challenges, which is in the field of gynecology or obstetrician, you really need somebody who's dedicated and really have that expertise. So what I hope to see, and when I also would see this as something that has been successful, is that we have more clinics around Europe that can say, we have either a sort of a joint clinic where there's always a hematologist and gynecologist involved, or we have a very dedicated collaboration. So we know that we send all the patients to the same gynecologist or the same clinic. So we know that that specialist also have a high level of understanding of bleeding disorder, as well as the whole reproductive system, gynecological issues in general, because that is some of the most, I think, significant gaps we have here now. But all of this also rely on that we have women diagnosed. We need to get the delay in diagnosis down. It would be very nice to see in 5 and 10 years' time that the delay in diagnosis is not 8 to 16 years delay compared to the male counterpart, but it would potentially be 0 or would be 4 or 5 years. But to have a lot of women not being diagnosed until potentially they're 16, 20 years old, considering that they have started their period when they're maybe 10, 11 years old, 12 years old, that's just way too late. Way too late. And it's not, I don't think as a healthcare system we can be proud of that. Like, it's something that is actually quite measurable, and something that I hope these principles really can highlight for the healthcare professionals within our bleeding disorder community, but also in the broader sense that we can use that to talk to other specialties, that we really need to get involved to actually change some of these elements.
It is not easy to measure, but if we can do some in a couple of years, that would be awesome. And I really do see it as a great step to get some recognition. And if we can provide this recognition and see that women are more included into the ACCs, and that also the treatment is getting better. Because there we do see that it's lacking in the system as well, that the treatment is not equal or not the same compared to a male with bleeding disorders. So if we can have this recognition and these small changes coming up, I hope that we can continue working on it in the future and change the principles of care also with the data that we collect in the coming years, hopefully. But to be honest, it's not an easy process. It's a slow process, but I'm very confident that with the bleeding disorder community who really is into the momentum and see what is needed and that changes is needed into the community, also the care providers as well. So I'm confident that we will see, although it's taking a time, the changes and that we are faces the challenges that we are dealing with.
So these principles of care, they've only been around for just 2 years, I think, but they're already a top, like 6 months ago, they were a top-cited publication in the publication in Wiley. And I think that highlights that there's actually a lot of people out there who really think that this is something we need to move forward with, and really recognizing that this is something that we haven't really achieved doing yet, and really is something we should prioritize achieving. So I think that's something that it might not be a success yet, and there still might be a lot of things that we need to change, but just that small thing is also a recognition of the need that these principles are kind of serving. And following that, we are actually going to conduct a survey that is also going to follow up on some of these principles of care to try to understand, okay, so you have these principles of care, but how is it going with the implementation? What additional information or what additional education do, in particular, healthcare professionals need in order to move ahead with this? What is it that are we know some of the constraints, but we also need to know a little bit after they are out there. What is it in the reality that the healthcare professionals really need of support in order to make these changes in both in the hospital setting and like in the clinic settings, but also potentially down to the dialogue clinician to a patient, how that's going and what's needed to improve that. There is a lot of conversation on shared decision making, in particular when it comes to gene therapy. But one of the things I really see also would require some more dialogue and improvement, which is touched upon in the principles, but could be something we need to investigate even further. And that is the whole hormone treatment, reproductive systems in women. And how we have that conversation when it comes to what treatment do we offer young girls and what treatment do we offer women who are in fertile age or reproductive age and want to reproduce. How do we deal with these aspects? Because they haven't really been highlighted well enough, the challenges that is associated with that. And more research is also coming out about hormone treatment and the impact of that. And if we need to start recognizing some of this research coming out, we also really need to really start to dive into more of these tools that we have designed for other treatment regimes, for example, gene therapy. But how do we use those as learning points when we have all these difficulties that we see with our patients, in particular in hormone treatment and reproductive system? So that's something I also really hope to see is some learnings that we can add into this and potentially improve either the principles of care or some additional elements to that.
Yes, I totally agree. It has been a great start for moving forward, but it's also a process that will continue, and we will learn more and more with the years. And what you do see is that more research and outcomes are coming up to us, but also requests from the women about issues that they raise, but has not always seen by the care providers. So it's an ongoing process, and I think the first steps have been made. And in a couple of years, maybe there will be a review coming up. But I hope this, for now, will be very helpful for healthcare providers, for NMOs, for patients to at least make it better for themselves and get better care, treatment, but also an earlier diagnosis. And that would be the first steps that we can make.
Excellent. Thank you very much. Thank you both for your time, and thank you for listening. Stay tuned for the next episode.